Hi, everyone. Welcome to the Reframing Eye Care podcast. Our guest today is Dr. Lauren McLoughlin. Welcome to the podcast.
Thank you, Maria. This is awesome. Very excited about this.
Yeah, I'm excited to have you on too. I think you're doing great things in eye care and dry eye, practice is something I think a lot of doctors ask about and are interested in starting. So I wanted to have a dry eye expert on the podcast and talk about how you've succeeded and what you've done in your career. Just maybe help other ODs. But for those of you that do not know Dr. McLoughlin, she went to Brooklyn College undergrad, SUNY Optometry School, did a residency at the VA in Delaware. She started a dry eye center about 8 years ago and practices at Eyesight Ophthalmic Services in New Hampshire, and recently started a residency program with, for students in July of 2024, and is a preceptor for Drexel, NECO, and SCO. So, I know you're passionate about dry eye and the role of corneal nerves and neurotrophic keratitis. Tell us about your journey and how, you started the center and then wanted to precept and then, residency to educate the future leaders of eye care.
Yeah, I feel like it's really important to give back to the younger generation. I've had a great career. I started I've been practicing since 98 when I finished my residency. I was in a big MD-OD office, doing a lot of medical optometry, primary care. We started taking students in 2012, maybe the class of 2013 from SCO. One of our associate doctors at the office is an SCO alum. So that was where we first started. And then we took on PCO, which is now Drexel, and we took on NECO. We haven't had a student yet, but we are now affiliated with MCPHS as well. So those students will start. I started the dry eye clinic about 7 or 8 years ago. We had a huge need for it. There's so many people that are, really suffering. A lot of them are suffering, but a lot of them are dealing with dry eye. We have a lot of surgeries that go on. We need for the ocular surface to look really good. And we developed this dry eye center. I went down to Dry Eye University, got some fantastic ideas from them, and came back on a Monday and literally put it into motion. I have a dry eye counselor. I have a dry eye workup tech. I have a dry eye scribe. And it really, really helps during the day. We picked out techs that do have dry eye. So they're definitely more vested in helping the patients. They've also had a lot of the treatments. They use a lot of the meds. So the patients are talking to people that have actually done the procedure or are using the current medications that are out. And that is super helpful. About 3 years ago, we started thinking, wow, we have all these students. Wouldn't it be fantastic to have a residency program? We have so much to offer a resident. We have a corneal specialist. We have a LASIK center. We have a specialty contact lens doctor. I run the dry eye clinic. We just thought it'd be an amazing thing and reached out to NECO, and we had our first resident come through the program. She started in the fall of 23. She finished in June of 24. And in April of 24, they came and we had our big interview for accreditation. And we found out in July of 24 that we are nationally accredited now. We have a cornea specialty contact lens with a little bit of a specialty in dry eye. So we're a little bit unique. And we're also unique in that we're a private practice. So we're not academia. It's really giving someone what it feels like to be in private practice versus being at academia, where I think sometimes you get a little more time to be with the patients. Whereas in private practice, we don't want to rush anybody out, but we know we're on like a timeline. So really teaching a resident how to really be efficient in those full dry eye workups and taper a plan, but don't have the patient there for an hour and a half, 2 hours. So we're pretty efficient.
Yeah, I mean, even just insurance things, right? Those are huge.
Right.
That we don't even learn until we get into practice. I'm like, I would love to give you this drop, but insurance doesn't cover it. What do you do? I mean, it's kind of as you learn as you go, authorizations, things like that. And I think that's a valuable, asset that your, clinic has for these residents.
Yes. And also, I'm extremely fortunate with such a large practice. We have an actual office that does PAs for us. But even then, you get a patient who gets a PA and the out of pocket cost is still really, really expensive. So it's all about like constantly reading new things and keeping up with the latest technology and seeing how you can get some of these meds to these patients, because there's definitely a need. And there's so much stuff out there right now that works so well. And it's not just, one thing. You have to figure out the right combo. But sometimes we have to be super innovative and inventive to get patients what they need for dry eye clinic.
But the doctor starting out, I mean, how did you, I mean, I know you went to a conference and you jumped right in, right? How did you figure out how to design? Did they give you those options? Did you like make a lot of mistakes at the beginning?
Oh, yeah. Yeah.
Yeah.
Sometimes it was almost like, just kind of feeling things out. Sometimes it was just a slit lamp exam, like putting stain in, looking at corneal stain, conjunctival stain, doing a tear breakup, just doing the simplest things. And that's what I always tell doctors that are looking to start a dry eye practice. Start with simple. You're going to find so many things and you're going to figure out so many different ways to do things just based on going super simple. Yes, the toys, we have all the bells and whistles and it's fantastic, but you don't need to start that way. Start with a slit lamp exam. Start with a cotton wisp, checking corneal sensitivity. It really is. I always, when I do some of the dinners, I always joke around. It's like the field of dreams. If you build it, they will come. And once you treat a few patients who are successful, you will see word of mouth. I have so many patients that are at our clinic. I get people that travel for miles to come because a friend told them that I helped them with their dry eye. So that's been great, but that's literally how it just starts like snowballing. And all of a sudden you're like, okay, I need to start not seeing regular patients. I need to just start doing dry eye because that's how quickly the schedule fills up.
Yeah. I mean, you touched on corneal nerves. I mean, let's talk about that. I think it's something overlooked in a lot of clinics. Some doctors don't even think about it. Maybe it's something, underdiagnosed or misdiagnosed. Can we talk about that? And, again, you need a slit lamp and maybe,
That cotton wisp, right?
cotton wisp. Yeah.
Yeah. Yeah, until 2019, I was probably like everybody else, just, okay, this is dry eye. This patient has SPK. I've tried everything. It's reoccurrent. And then once I started really learning about early NK, I started thinking, wow, a lot of these patients that have been in dry eye clinic for years, maybe they're actually neurotrophic. And then when you start looking up at all the different things that could cause neurotrophic, one being chronic dry eye, you start realizing that, wow, if I don't address those nerves, I don't know how much better I'm going to make this patient. And so I kind of reversed my whole philosophy. I use the nerves, the corneal nerves as my base. I check them at every full dry eye exam, especially new patients coming in, and then figure out, okay, so the first thing is this patient's nerves are not working. So now we need to go a little bit different. Yes, they still have Sjogren's, they still have MGD. But just by getting nerves working better, you're increasing tear production, you're increasing blink rate, you're helping with corneal wound healing. So sometimes that's just the kickstart that you need to help that corneal, like that whole surface and the whole homeostasis of the cornea.
How many of those patients do you usually see a week? You think it's pretty common?
I think it's a lot more common than we think it is. It is still considered a rare disease, which is definitely, I think it's like, I don't know, 1 in 16, I think they think actually have early NK. But I think it's just not being diagnosed enough.
Yeah, of course. Usually a lot of the dry eye, I think, are diagnosed by symptoms. How are you feeling? Feeling better? Okay, great. You don't need to see me anymore. Have a good day.
Right. So when you really get down into it, the biggest one I think that gets missed is diabetics. 50% of diabetics have corneal neuropathy, just like their fingers and their toes. We ask them about peripheral neuropathy. We can't ask them, so is your cornea numb? They can't like articulate that to us. So it's our job to check those patients and make sure that if they have corneal neuropathy and they have SPK, that we're treating that and doing something about that.
Yeah, I think that's a good pearl that just taking out this podcast, just that I think is important, the diabetics, as we see a lot of diabetics, right? So I think
Yeah,
that's
you
very
see a lot of
important.
contact lens wearers too, right? Like even if you're just in, I always say that even if you're just in primary eye care, you're seeing glaucoma patients, you're seeing diabetics, and you're seeing a lot of contact lens patients. For a primary care practice, those three right there, you should be checking nerves.
Yeah, of course. So you've been super successful on this. Can you tell us what you think has been the, you know, the most positive things and what other doctors can kind of mimic for their own practices? Because
As far
there's
as checking
failure
for
in it.
nerves, yeah, like I think it's really just being super like looking at that medical history even before you go in the room and thinking like, oh, this patient maybe like they have a few complaints. Like I find like photophobia and blurred vision are the two big ones with NK, early NK. So they're not going to complain to you about pain. Like the signs and the symptoms sometimes don't correlate. Before I even go in the room, sometimes I'm like, oh, we should really make sure we check this patient's nerves, because I just feel like looking at what they're complaining of and looking at their medical history, there's a good chance they might actually have NK.
Yeah. For doctors starting a clinic, I know you said slit lamp and things like what if this first type of equipment, what would they purchase? And then obviously slowly build. It's an investment, so a lot of doctors don't
Right.
have that kind of income, but building up, what would be the first few tools that they would purchase?
Yeah. So, I mean, just even getting the inflammatory test, that gives you so much useful information in a dry eye clinic. So, I honestly, I don't lissamine green unless I really have to. I don't rose Bengal because I try to do the least amount of testing that's not going to annoy my patient and gives me the most information, like the biggest bang for my buck. I'm a huge fan of inflammatory. Just seeing if that patient has do they have inflammation? They don't have inflammation. That could completely change the way you treat that patient. So inflammatory, that's a great one to get in. And it's just, literally looks like a pregnancy test. And although you don't there's no code for, well, light pink is this and bright pink is that, you kind of start learning, like someone who comes up fluorescent pink versus the light pink, well, they have a lot of inflammation and that test turns pink immediately, versus those patients where it's just kind of light pink after 10 minutes. Well, that patient's doing better than the patient who has like fluorescent pink. Regular fluorescein strips and literally cotton swab, so that you're bringing that patient in. A speed score, super cheap, super easy. We keep ours laminated with a dry erase marker. My tech gives it to the patient and then she wipes it down after, she disinfects it, and we use it for the next patient. So we're not, some of my patients are definitely an older population, so going on their phone is really not an option. If you have a younger population, you can literally download a speed score right onto a phone where they're sitting there waiting to be seen. Hey, can you just fill this out for me? A little speed score. But speed score, case history, some fluorescein stain, a cotton wisp, and if you want to start with inflammatory, you are going to find a lot of dry eye patients. Once they're in the slit lamp, you definitely want to do a tear breakup time. You want to press on those glands, see if structurally they're working, what's coming out of them. I mean, just that, if you don't have a meibographer, just pressing on someone's glands and seeing if something's coming out and what type of substance is coming out is going to give you a ton of information about MGD. Flipping the lids, looking for papilla, is it allergic? Definitely, I always tell the students, look at the lid position. That patient has epiphora because they have punctal eversion. So there's so many things that just doing a slit lamp exam, you could figure out some of the patient's symptoms in dry eye clinic.
Of course. And then tell us about the other cool technology that you have.
So we have a Blefx because I totally believe in debriding the lids before we do any type of expression. I am a huge fan of meibomian expression. When their glands are obstructed, they cause inflammation. One of the ways you get rid of inflammation is by getting rid of the obstruction. So I'm a huge fan of tear care. I use tear care and IPL for most of my inflammation if a patient can afford it. If a patient can't afford tear care, I literally have them come in with their Bruder mask. We have a microwave in dry eye clinic, and I heat them up and I express them. And I bill it as like a level 3 because I looked at cornea, I looked at conj, and just a medical visit. I don't even charge them extra for it because a lot of the patients that I have couldn't even afford like $100 for a manual expression.
Oh, that's great though. That's great. I think that's a great point for doctors too. Like you can do some of that. When I first started doing some dry on my practice, I wanted to see what the reaction was from patients. So I did that too. I'm like, all right, you're going to buy a brooder mask. You're going to heat it up. I'm going to extract the glands and see what the outcome was. And patients appreciated that, right?
Yeah,
So I think there's a good
definitely.
way to get. So here's your patient base that is interested in this. They feel some relief. And maybe if they can in the future, that might be your pool of patients that will pay for your IPL, right?
True. Yes. And then there are some where, if someone has really, really severe MGD, we're talking like someone who has maybe 3, 4 glands left in each lid. You do a tear care on them. It doesn't really do much. Where, my wheelhouse for tear care is mild to moderate and almost severe. Someone has 2, 3 glands left. Those patients are coming to me every 3, 4 weeks. We heat them up and I do a manual expression on them, and I'm able to just target those glands. I mean, they would never be able to afford a tear care every 3, 4 weeks. So, I try to help the patients out. I'm such a believer of meibomian gland obstruction that this is my go-to if someone can't afford a procedure.
Of course, yeah. So tell us about your residency program, how you did that, how you're not in academia, kind of a dry eye residency. I think that's new in eye care, right? Dry eye residency.
Yes.
Yeah.
Yeah. And I think a few of the cornea programs do have some dry eye, but not where they're like in a private practice with a dry eye practice. Yeah, it's been great. We have so much opportunity for a resident. They get to rotate with the corneal specialist 2 days a week. They come to the LASIK center 2 days a week. At the LASIK center, that's where we keep our IPL. So they get to watch or do IPL, whatever they choose to, pre and post-op LASIK workups. We also do LAL adjustments for the LDD on LASIK days. So I have a resident who is actually certified in LAL adjustments. I don't know how many other residents can say that across the country. So that's been really, really nice. They go to specialty lens clinic on Thursdays, and then Friday, we let them kind of have a mixed bag of patients. They're still new doctors. We don't want it to be all anterior seg and forget how to do posterior seg. So Fridays, they see patients from like 8 until about 2:00. Friday afternoons is their admin time. They get to do like journal club with the students or a case study, catch up on their charts. But it's been great. There's 4 of us that are involved in the residency program, and I can speak for myself, and I know the other 3. We love it. We have so much fun mentoring the resident. I mean, I love being with the students too, but there's something about the resident. It's just teaching someone those advanced competencies and really just letting that doctor know like how important it was that they took that extra year out of their career to come and learn advanced competencies. Like it means a lot to me. I was a resident at one point, and I just think it's a really cool thing.
Oh yeah, of course. Yeah. But they want to be there, right? I mean, they
Yeah,
chose that special. So it's nice to have that passion because you have the same
absolutely.
passion, right? Instead
Yeah.
of the students that, might want to think about dry eye, but maybe they don't want to do that. They want to do myopia management or something else like
Right,
that.
exactly. Like, right, if you rotate through my clinic, you're in dry eye with me. Maybe dry eye wasn't your thing, but the residents are doctors that are choosing that on, but they have that same passion that I do. They're there because they want to be there and they want to help patients.
Yeah. Well, thank you so much for coming on the podcast and sharing your story and talking about dry eye. I think the doctors could take some pearls from this, but also for what you do for the profession and educating the younger generation and future dry eye resident doctors that will help patients and maybe what other doctors will refer to in the future.
Yes, it's very, very cool. I enjoy it.
All right. Thank you so much, doctor.
All right. Thanks, Maria.